Good morning and welcome to COVID-19 Talk with local health authorities. Joining us this morning is Dr. Janina White, who's sitting in for Dr. Erica Brown from Harris County. Also, we have Dr. David Purse representing the City of Houston. Special thanks to past President, Rotary Club of Houston, Kathy Feniger, for providing these questions. Our producer today, David Castillo. I'm Stephen Williams, Director of the Houston Health Department. Currently, what is the definition of fully vaccinated? That's a good question.
I'll take that one. So fully vaccinated is when you've had your primary series of a COVID vaccine. Even if you've not been boosted, you've had the primary series, but we still encourage, if you've not been boosted, please get your primary series and then get boosted for additional protection.
What is the status of wastewater?
Yeah, so there's some good news there. Our local wastewater COVID numbers are way down. We're not quite at the lowest that we've ever been, but we're absolutely in the neighborhood. We're in the 30-40% range. That's the percent compared to the peak of the first wave in July of 2020. Also, our local hospitalizations for Harris County, as an example, most of the folks that are admitted that have a diagnosis of COVID are really admitted for something else, and it's incidental that they have COVID. There are some people who are admitted because of COVID problems, but most of them are co-infected with COVID and their primary problem. And those numbers are actually lower than they've been since before that first wave. Our very lowest numbers were obviously before the first wave, but we're in that same neighborhood as well. So right now we are absolutely looking good for COVID. But we are watching carefully what's going on in Europe and in the Northeast, because things are taking a turn in those locations. So we got to keep our guard up yet.
Of course, the numbers are down in Harris County, but is that true for all age groups?
They're asking for COVID.
Yes. Yeah. Or the
So
COVID for
yeah.
all.
Yeah, so right now our county indicator and city indicator, we're in level green, so we're in low, but we're still keeping a close eye. Like Dr. Purse said, we're watching what's happening in other parts of the country, particularly the Northeast. So, we certainly don't want to let our guards down with regards to being prepared for our strategies for our toolkit for COVID. All those things that we knew from before are still applicable, and certainly vaccination really is what we're really pushing individuals. If you've not been vaccinated, if you've not been boosted, this is the time even for those little ones who are now candidates to get booster vaccines.
Okay, David, you got to take out your crystal ball. CDC shows wastewater with BA 4.6 going up in the Boston area, and hospitalizations have increased in the Northeast. Since we have followed that area by a couple of weeks, what are your predictions?
You make me laugh, because one of my new mottos is, if you want to make a mistake, make a prediction. So let me go ahead and make a prediction, right? Yeah. I think that we're going to see another wave. My fear is that it's going to be probably during November. So currently local, so yeah, BA 4.6 is not making up a huge percentage of what is being seen elsewhere, but it's present. We haven't, I've not gotten any reports that we've seen it. Now, what we do have is we do have a variety of different forms of Omicron, including BA4, and we actually still have a little bit of Delta floating around. The thing that has me most concerned is that if we get another wave coming up here in November, that may overlap, because our influenza numbers are going up, and RSV is actually very active already. And so if we get, the triple whammy all at once, it's going to put a huge strain on the hospitals.
CDC is no longer doing daily tracking. Is that wise in areas where cases are up? Does it even matter?
Yeah, so this is a really good and really important question. So the purpose of contact tracing and case investigation early on in an outbreak is for containment. And I want to remind folks that here in Houston, when we had our very first cases of COVID from the people that were on that Egyptian River cruise in West Houston and in Fort Bend area, we were able to contain and basically stop the spread of it through contact tracing and case investigation. But then at some point, it just gets overwhelmingly huge, and you can't contain the virus, where somebody spreads as easily as COVID did. So at this point, it's for academics to learn about the virus. And so we've learned an awful lot about it. Now, as we get new variants, we need to investigate those. But the task is overwhelming when we get the numbers that we get now. So it's, it's hard to say if it's, if it's worth it when the numbers get to be so big that you can't make sense of the data.
October 13th, the U.S. extends COVID-19 public health emergency declaration for another 90 days. Does this provide those in public health any additional resources? No, it doesn't. I think what it does is just continues to acknowledge the fact that we're still in a pandemic. There's still a lot that we don't know. I mean, we're hearing the discussions from health authorities. We'd love to have that crystal ball to determine what happens. But I think, the declaration is in place, acknowledging that we really don't know where we're going from here. Are we having an RSV crisis in hospitals?
So we're certainly hearing that our hospital partners in other parts of the country are seeing sort of this RSV surge. I think in the Atlanta region and out east, even in the Atlanta region, they're looking at some alternate models for hospital, so that ER attachment for giving care to kids. Here in our area, we are monitoring RSV very closely. We have heard that our pediatric hospitals have had an increased number of individuals with the RSV. We're sort of in a state in our region where we have a lot of pediatric expertise in this area, but we also know this RSV, influenza, and COVID. So we're really wanting, families to understand, when you're thinking about your children, certainly flu vaccination is important. Get them vaccinated for flu. We have COVID vaccines for children 5 and up. But, RSV is often seen in the most vulnerable little babies, 6 months, 7 months, 1-year-old, and then even individuals who are elderly who have immune compromising conditions. So this is one to watch, and we're prepared, and I know our hospital systems are really doing the best they can. The other thing I want to mention, though, is kudos to all of our hospital workers. And we know our hospital workers are, fatigued, and we've seen workforce shortages. But what I know to be true is that no matter what, when they see issues like this, critical need, they're always going to step up to the plate.
Medication. MedPageToday.com reported on ivermectin, noting that there was no benefit for mild to moderate cases, and the findings do not support its use. Is there any effective medications?
So, yeah, there are some effective medications, and in fact, the FDA is working hard to get more authorized and available. When you say that's a pretty broad question. So there are some, pill forms, there are IV forms of medications that can be taken, but there are others. But ivermectin, a lot of debate about that, but it never really looked like it was actually making a difference.
Paxlovid is not being consistently given. Is it still considered effective?
So it's still one of the tools in our toolkit. And so that person asking that question, you're exactly right. I think we have an obligation to make sure communities understand that that's a resource that's available. We do know there's some equity issues. And so this question speaks to that. And we need to do a better job of making sure that people know that those tools in the toolkit are available. So Paxlovid is still used for mild to moderate exposure of having COVID symptoms. And if you have those risk factors, your provider should be making you aware that that's a medication to discuss with you to see if you're a candidate to be on it. And then you make a shared decision about being able to use it.
Can you discuss any preventative medication when you're exposed to COVID? I'd expand that to preventative measures.
Yeah, if you're exposed to COVID right now, there's what we call like the PrEP. There's no preventative medication. There are medications, though. Evusheld is one that most people hear about. If you don't have illness but you're at risk, then Evusheld should be a medication that, again, your provider should be speaking to you about being able to use. And certainly the equity, again, is that the state has it available. It should not be a barrier if you are depending on your insurance status, it's available across the board for people in our region, across the state. And if you have mild to moderate symptoms, then we have medications, which we just talked about, the Paxlovid, the Lagevrio, and some other additional medications as, again, options that your physician provider should sit with you and talk about to see if that's the right decision for you.
Since we aren't sure exactly how long immunity lasts, what is the minimum time to wait for a bivalent booster after having an infection? I will be traveling over the holidays and would like to have as much protection as possible.
Yeah, so this is a great question. And what we believe is that after somebody's been infected, they generally, from that infection, they produce antibodies and they are generally protected in the 3 to 4 month range. So if you were to get vaccinated, get a booster, for example, within that period, it really wouldn't add any benefit. So in order to make your protection as long as possible, the recommendation is that you wouldn't get vaccinated sooner than 3 months. Now, that having been said, should you be in a special situation where perhaps you're caring for somebody with a chronic illness, or perhaps your employment where you work in a nursing home or something, you may want to talk to your provider and consider getting it a little bit earlier. But generally, it's wait at least 3 months, because there's no extra added benefit doing it less than 3 months, because the infection gave you protection.
According to a recent study published in JAMA, Network Open Journal, robust Pfizer-Moderna vaccine side effects show the vaccine is working. What does that mean for those who had no reaction?
Again, I've not read that study, but just anecdotally talking to people who I know who've been vaccinated and boosted, there are people who just said that they did not have a reaction where they thought previously they had sort of that arm was sore, they felt maybe a little bit under the weather for a couple of days. So not having those symptoms doesn't mean your vaccine was not effective or you didn't get the medication. Just it's variability in how we respond to being vaccinated.
CDC approved Novavax monovalent boosters for 18 and older. What are the benefits? Will it last longer than the mRNA boosters? I've received my last Pfizer in September. How soon could I get a Novavax booster? Please reiterate who should take monoclonal versus bivalent vaccines. Unwrap that.
Yeah, so that's a good question. So the Novavax is a fine vaccine. It's got high protection rates. The thing is, it's produced by the traditional method. So a lot of people had anxiety about getting vaccinated with an mRNA because it was a new technology, and they had heard all kinds of malarkey really about why it was dangerous or something. It's all wrong. But anyways, if you are somebody who had that concern, you can get the Novavax, and they've now approved it for booster as well. Because it's out new, we have to wait to see how long it's going to last. There's no reason to think it'll last any less long than an mRNA. Perhaps it'll last longer. We're going to have to wait and see because it's only, in the last couple of months been out. And so we're going to have to, get a real world answer to that question. But yeah, so if you are unwilling, or perhaps you had a bad reaction, an allergic reaction to the mRNA, you're allergic to one of the preservatives or something in it, and you can't get another mRNA, then you would want to think about getting the Novavax vaccine.
Big news this past week about how much Pfizer will charge for COVID vaccines after the government stops paying for those with insurance. Isn't this consistent with other recommended vaccines that usually have zero copay?
So I think, with other traditional vaccines, the insurance carrier will pick up and has a market value for you being vaccinated. Certainly for public health, one of the things that we stand prepared, and I think Dr. Stephen Williams mentioned this earlier, is, what role does this declaration play? What opportunities does public health have in this space? And so certainly individuals who are underinsured or uninsured, this is where public health is looking to see how to ensure that equity for individuals, to ensure you have access to vaccines. Because what we don't want is to see, again, a disparity and inequity, that vaccines we know make a difference are not available to everyone who wants to get vaccinated.
I'm so excited to get the bivalent, and I'm surprised that only a very small percentage of the U.S. have received it. For those who have been getting the boosters, why the reluctance now, especially with those over 65 who have been considered more vulnerable?
Boy, if this isn't the $60 million question, right? If we had a good answer to that, then we wouldn't need this question. It's one of the things I can tell you is that our hospital partners that we're working with and been working very closely with for couple of years now, several years, almost 3 years now, they're telling us that, of the patients who are admitted, and I mentioned earlier that the number of patients admitted to hospital with COVID today are very low, and they're co-infections. But among them, they're almost exclusively unvaccinated individuals. So the vaccine, and for the few that were vaccinated, these are people who've got complicated medical problems, a lot of comorbidities, and as we age, and as the questioner points out, as we age, our immune systems start to falter. And one of the things they'll do is they won't respond to vaccine quite as well. And so even though they got vaccinated, they may not have gotten the level of protection, and hence they wind up in the hospital. So if I had a really good answer to this question, we wouldn't need the question, but it makes the data is quite clear. The people who are getting hospitalized even today are almost exclusively unvaccinated individuals.
So we should continue to push for folks to get vaccinated, including getting boosted.
Yes.
What is the bivalent Omicron effectiveness against the new variants? All the variants appear to be mutating. Are they evading the bivalent vaccinations?
So data right now, is going to be forthcoming because we just now rolled out the bivalent. But what we knew is when they made the bivalent, they were very mindful of looking at what variants were coming down sort of the track, and that BA4, BA5 was in that consideration, which is what's in the bivalent. So that's the good news. The challenge is if people don't take the bivalent, you're giving the virus the opportunity to do what you just mentioned, which is to continue to mutate and make new variants. And so again, we're watching what new variants are on the horizon. Some are escaping, but it's still too early to tell what this bivalent means for those variants. So really what we want everyone to understand is what we know about bivalent vaccines at this point is that they're effective, they're safe, this is the time to take them so that we don't start to see this new variants of the BA, the BQ, the XBB, and there's like 200, right? And not all of them will be viable in essence, but not getting vaccinated is what's also creating this opportunity for these variants to sort of take one track on their own. So bivalents are safe, they're effective, and they were thought in mind of the current variants that we're seeing right now, which is the BA4 and BA5.
Just building on a follow-up question, have there been independent validity studies on the bivalent vaccine, or are we trusting the manufacturer just like we do for annual flu shots?
So this is a great question because I think a lot of people don't understand that the annual flu shot is put out without the scrutiny that we all came to be aware of with the initiation of new mRNA vaccines, because they don't need it, right? We know that they're safe, and then we have to wait and see how effective they are. We can't do the complete validity studies because if we did, then the whole flu season would be over. So the idea or the practice of putting the shots out with the vaccines out without doing the total validity studies is not uncommon at all. And we are at that point now with the mRNA vaccines that we can do that. And one thing I want to point out is that in Europe, they went with a bivalent that was BA4. At the same time, the manufacturers presented that data to the FDA, and the FDA sent them back and said, no, we want one with the BA5. And I'm glad that they did, because that's what we're facing now. And so they did get, but now that they still have safety studies that are done, but they don't have the entire scope of validity studies. We'll have to wait and see, if there's a surprise there, and there might be because of the new variants that come along. But but what's being done is not uncommon. It's not unsafe, and because of time constraints, this is what we have to do.
Do we know whether receiving so many vaccines in a relatively short period of time creates resistance, like too many antibiotics?
So I don't think we look at it like that concept of having a resistance to antibiotics. What we, I think, want to ensure is that the vaccines are being developed with the consideration of what's best with regards to the virus and then to that variant consideration. And so, you know, to Dr. Purse's point, right, there's a lot of people looking at safety data, looking at what's coming as far as variant data. So what he said, had we not really taken the scientists' information most applicable to our region, we would have just had a vaccine that would have covered BA4. So now we have individuals saying, no, you need 4 and 5 in that. And they're also looking at what duration, what durability. So thinking of it from a resistance of antibiotics is not really equivalent to thinking about it with regards to viruses and how we're going to get through this, this pandemic, in essence, with regards to ensuring that we can sort of slow down the mutations that viruses do when they're left sort of unhinged and non-covered and people are not vaccinated.
Vaccine records in Texas could potentially be destroyed 5 years after the statewide public health disaster ends. Is anything being done to permit us to opt in for retention, or is our vaccine card the only proof?
Yeah, so this is a good question because I wasn't aware of that. A lot of so in Texas, we're, you know, the COVID vaccinations are being recorded in MTRAC 2. And MTRAC is a permanent thing. Perhaps MTRAC 2 is only the, you know, perhaps what the questioner is saying is true. Remember, with your primary care physician, at least with mine, they will track all of my medications and my vaccinations as well. That would be another option. And you should really have your own copy of all of your vaccines, ideally back to childhood if you have it, and keep them along with those as well.
And yeah, as an adult, you can opt into MTRAC itself.
That's right.
You can't opt in to MTRAC. So that if you want that, then there is a form that you can sign.
Let me add too, I mean, and you should consider opting in. I mean, certainly in our region, we have significant emergency events that happen. And then when you're leaving and you have those important papers that you may have forgotten, it's so nice to have that sort of repository set for you. So if you had to see a provider and decide if you need the tetanus booster or you need another vaccine, that's in the system. And it keeps you from maybe having to get a vaccine that you maybe didn't need at that moment. So there's some great reasons why having that repository is so helpful.
Yeah, it's quite convenient. I got my flu shot this past weekend with my own staff who was questioning me, and I just told them that if they were doing their job, they would pull me up in MTRAC, and guess what they did? They pulled me up in MTRAC and they saw everything that I had. Okay, variants. BQ1 is resistance to monoclonal antibodies and Evrushed, and what is this? Beta-lomad? Is it more evasive variant true? And tell me how to say those words correctly.
So is it beplitamab? And
there
then you said you said the other one, fine. And there, you know, we know that the BQ1 is slowly upticking. It's about 17% right now. But this is really one of the better tools we have still in the toolkit for what we're seeing sort of in a larger scale. So more to come on how effective Evishield will be over time, but it's certainly one of the tools we want people to know they should have access to.
Vaccine rates have decreased while cases have appeared early. Any news? I'm not so sure that's clear.
This one was, I think, flu related. And so there's a lot of dense information about flu. So we are seeing increases in flu hospitalizations, flu testing. So I think a couple of weeks ago we were at 1%. Now we're already at 4%. And that's pretty significant. And we're just beginning of the flu season. So October is just the beginning. I know here at the Houston Health Department, if you go to our webpage, we have at this time of year, we'll put our flu surveillance information. So that's going to be updated. I believe it's every other week so that you can actually see what's happening in our area with regards to flu. And then all of our locations now are offering flu vaccinations. So if that's something you're interested in, you know, again, we'll drive you to our website to see flu surveillance information and the access to get flu vaccinated.
Neuroscience News reports those with pre-existing conditions, anxiety, depression, chronic stress, and distress caused by loneliness are at a 50% increased risk of developing long COVID following COVID infection. Is that true, and why?
Yeah, so it's easily explainable. When you have those conditions, it creates a lot of emotional stress, and your body produces a hormone called cortisol. And cortisol, unfortunately, negatively impacts your immune system, making you more susceptible to, not only getting primary infection, but also long-term problems. So that is easily explainable. Yeah.
Okay. Native medicine commented on a study to understand genetic factors that influence the level of antibody responses to COVID. Are genetics common in differences with COVID viruses in general?
So again, it's hard to know if that question is genetics as a ethnicity race. So what we just, again, I think I've said a couple times in these questions is that whole equity and understanding in the research and having groups represented. So from a genetics consideration, it's important to consider. I think we don't know what we don't know. And so when we start looking at some of the data points with regards to who we see most impacted by a lot of these viral illnesses and infections, it's important to also understand other demographics and other data points, which would include that genetic component. So I think, there's just still more information that we would have to gather about thinking about it that way.
What is a genomic surveillance system?
So a genomic surveillance system is when, and we've heard about this, is when samples that are in the community of people who are infected with any particular disease you talk about, and then they sequence the RNA or the DNA of that pathogen. So whether it be flu or COVID, and this is how we detect when there are new variants around. It's not uncommon, we've been doing it for a long time, but this is how we catch up, we become aware of changes, mutations, if you will, of whatever the pathogen is. And so I think the public has come to realize how quickly some things like COVID, which is an mRNA, can mutate pretty quickly. I'm sorry, that's not mRNA, it is an RNA virus. DNA viruses tend not to mutate quite as quickly because it's double-stranded, you need both mutations, but RNAs can mutate pretty quickly, and that's what we're seeing.
Boston University researchers testing of lab-made versions of COVID virus draws government scrutiny. Fact or fiction?
So it depends on how you wanted to answer it. So in Boston University, they took and they created a new form of the COVID virus on purpose. And it went through all the usual university processes. It had an institutional review board. It had ethics review. It had all of those things. But one of the federal funders of it, they forgot to tell them they were spending some of their money on this particular project, and that you can't do. So they're going back and they're under some scrutiny for that. But it was because they didn't notify one of the funders. It wasn't because they got around any of the ethics or usual laboratory processes before you do an experiment.
That sounds good. Thank you for joining us for COVID-19 Talk with local health authorities. Joining us this morning was Dr. Janina White, representing Dr. Erica Brown from Harris County, Dr. David Purse, representing the City of Houston. Special thanks to past president of Rotary Club of Houston, Kathy Finninger, and to our producer, David Castillo. I'm Stephen Williams, Director of the Houston Health Department.